Good morning, everyone, and welcome to the Public Safety for Substance Use Disorder Echo. My name is Julio Blanco, and I will be the facilitator for today's session. This Echo is brought to you by the Center for Substance Use Training and Telementoring, also known as CSTAT, by BWUD Texas in collaboration with the UT Health San Antonio Echo program. A few housekeeping items before we begin. We have live closed captioning available for today's session. If you would like to view closed captions for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. If you're having trouble accessing captions or having connection issues, please chat Echo IT Cato for any assistance. To help us with attendance, please enter your full name, affiliation, and email into the chat. Please remember to stay muted unless you are speaking. We encourage joining by video and using the chat and/or raise your hand feature to pose questions or share perspectives throughout the session. As a reminder, these sessions are being recorded and will be shared on our website. To ensure privacy, no personal health information is allowed at any point during the session. This includes client or patient names, addresses, birth dates, or any other identifiable information. At the end of the session, the Echo team will send out a post-session survey link. We kindly ask you to complete it as it provides feedback on how to refine these sessions to better address your priorities. We approve for CEs for paramedics and any public safety professionals with a behavioral health degree, such as social work or counseling credentials. Finally, Echo is an all teach, all learn environment, and we encourage everyone to participate in the conversation and raise questions. And today we want to take a moment to honor the victims of September 11, 2001. Many first responders lost their lives on that day, and I'd like to give our hub member, Brandon Del Pozo, a moment to introduce himself and tell us a little about his experience on that day.
Hey, thank you. As Julio said, I'm Brandon Del Pozo. I'm an assistant professor of medicine and health policy at Brown University. But prior to that, as some of you know who've been here week to week, I was a police officer for 19 years in the New York City Police Department, also chief of police for 4 years in Burlington, Vermont. So I was a rank of police officer working in Brooklyn on 9/11. Just doing routine sector patrol. We got the call to be mobilized downtown for the attacks. It's hard to believe it was 24 years ago today. Like it is here, coming to you from New York. It was a beautiful day. My own experiences were right there downtown as the buildings fell. It was only by the grace of God that my colleagues and I survived. But I think the thing to bear in mind is the terrible price that first responders paid that day, whether it was police officers or paramedics, firefighters, EMS, all sorts of folks. There was everyone who woke up that morning. It was a primary election day. Yeah, that's right. People were just expecting to maybe go to the polls, enjoy a beautiful fall day. First responders were just expecting to do their routine, sometimes heroic and always service-oriented work, but very few of them were expecting to make the final sacrifice. And we have a whole generation of people now that it was 24 years ago who are entering adulthood who weren't even born when this happened. So I think it's important to keep that legacy alive of the sacrifices folks made. And again, not just the first responders, but everyday heroic citizens as well, helping each other.
You got muted there, Brandon.
Oh, thanks for giving me, you've heard most of it, right? Yeah, thanks for giving me the opportunity to say that. And just, I guess today, maybe reflect on it a bit as we go about our work. And we take a lot of being first responders and people working in this type of sector for granted, but you never know when such an acute challenge could arise and what it might ask of us. So thanks.
Thank you so much for those words of reflection, Brandon. With that, I'd like to move on to some other introductions. We have with us today Dr. David Miramontes.
Hi, good morning. I'm Dr. Dave Miramontes. I'm the medical director and chief medical officer for the San Antonio Fire Department. And we do a addiction program. In our program, we're paramedics getting people engaged in recovery with buprenorphine and other referrals.
We also have Cynthia Mendiola.
Good morning. Hi, my name is Cynthia Mendiola, and I am here enjoying the different curriculums that are provided. I'm a retired federal probation officer, and I work also as a trainer and coach for core correctional interventions, and happy to be here. Thank you.
Thank you. And lastly, but certainly not least, we have our last hub member and didactic presenter for today, Jeremiah Goulka.
Hi, everyone. Jeremiah Goulka, Executive Director of the SHIELD Training Initiative at Northeastern University. We provide occupational safety and health training for first responders in their work responding to the overdose crisis to reduce stress and burnout and improve effectiveness. And I'm also starting a program there called Climate and Public Safety, which is related to the presentation I'm giving today.
Thank you so much. So with that, let's go ahead and move on to our didactic presentation for today. Jeremiah, feel free to share your slides and start.
All right, here I go. All right, you see the cover slide there, it looks like? Great. All right, cool. So today I'm going to talk about, well, we're talking about weather emergencies, but it's, the leading off by thinking about what happened 24 years ago today is also relevant when we're talking about weather emergencies, but other kinds of disasters will fit in, and how that affects encounters between populations who use substances and first responders and public safety professionals. Got no financial or commercial interest to disclose regarding this, and there's the disclosures for the university. So here's what we're going to talk about. We're going to do this is a preliminary look at how weather type emergencies can shape encounters between first responders, public safety, and people who use substances. How it increases the number, they can increase the number of encounters, the friction of the encounters, and what can be done to try to mitigate that that friction and to build trust. Would really love to hear from you. This is very much preliminary and exploratory work. And so we're gonna have some polling. We'll have if you want to put things in the chat to speak up during the Q&A, it would be excellent. So the first thing we're going to do is ask you all what you are experiencing, and I'm going to switch the share now over to little poll everywhere. So let's see. So if you could be so kind as to, using your computer or your phone, use this QR code or this URL, or use it. You can do this by text. Text the number 22333. And then the words in the text would just be SHIELD. But to use any of these approaches to be able to answer this question, you can see I've now switched the screen, but you can still see the directions at the top if you're still kind of logging this in. But the question I want to ask is, what are you all seeing in terms of weather-related issues and how they're impacting people who use substances, who you're responding to, if they're your clients, if they're yourselves, just any things that you want to offer, and pop those up. I see comments coming in. Thank you. I think I'll read some just as they're coming in. We're seeing flash flooding, high temperatures, heat stroke, animosity and irritability, dehydration, potential cold exposure deaths, heart problems and infections, flooding that can affect unhoused folks living inside drainage tunnels, creeks, and rivers near them. How can make people irritable, lack of air conditioning and shelter, flooding, disconnection from resources, unable to pivot. Got folks going to the libraries for the air conditioning, and then how is that connecting to drug use and how that affects the library experience for the folks, all the different people in the communities using the libraries. Just reading off what I'm seeing. I'll give you just another moment for a couple more if you want. Feel free to put in. I'm going to go ahead and pivot now back over to the presentation. We're going to come back over and do a little bit more of this Pull Everywhere fun towards the end. Thank you so much for participating in that. All right, let's make sure that the slide share is still working. Do you see what do you see right now? This is not showing me. There we go. Do you see it says what are you seeing at the top? I think so.
Yep.
All right. Great. So let's talk about some of the context that we're that they're seeing in the research. So when it comes to heat and substance use, this is the area that is the most studied so far. And I'm going to talk about a couple of different studies that look at emergency department visits connected to substance use. So if we're talking about emergency departments, this is just the tip of the iceberg, right? So on the left, it is a study from California, and in it, you can see at the top it's amphetamine use, cocaine use, opioid use. And at a certain point, if they start to tilt upwards, and then you've got at the bottom, it's amphetamine overdose, cocaine overdose, and opioid overdose, which sees even steeper curves. So that study, based on several years in California, the kind of midpoint is 61 degrees Fahrenheit. And you see the odds of increased use leading to an emergency department visit rising. The odds of overdose rising even more. So one of the ways that the authors express that is that for every 1 degree Celsius that increases, you have a 7% increase in amphetamine use, amphetamine overdose, and opioid use. And these have lagged effects too. So it doesn't automatically happen the day that it's really hot. It can happen over subsequent days, whether or not those days continue to be really hot or not. On the right, this smaller one, that is from a study of emergency department visits in New York State that looked at mental health visits. So what they saw was that for overall on the mental health visits, extreme heat was associated with a 28% increase in emergency department visits for mental health compared to non-heat days. Specifically, of that category of mental health visits, substance use related ones were the biggest fraction. They took up 42% of those visits. And that study included a lag period of up to 7 days. So there are going to be, of course, other factors beyond mere temperature when we think about heat. So for instance, solar radiation, relative humidity, and the heat index. And another New York State study of emergency department visits that were connected to mental health saw a very large association with visits regarding substance use. So now, why are we seeing this connection? As you know, stimulants and cocaine particularly have a heat can be impacted by heat in different ways, such as the risk of overamping, altered thermoregulation, neurotoxicity, kidney injury, dehydration, and electrolyte imbalance. Plus, for folks who are also taking medications for mental health disorders, that those medications may affect their body's ability to thermoregulate. And I'm just going to flag also that some of these issues can be particularly acute for unhoused populations, but I'm not going to go into that research here just because we're kind of squeezed for time. Now, there are lots of kinds of disasters. Beyond heat, though oftentimes they intersect, So let's talk about hurricanes. So after Hurricane Katrina in New Orleans, we saw the rate of substance use related hospitalizations increasing about 35%. After Superstorm Sandy, for folks who were in treatment and they could not get their maintenance therapy in sufficient doses in the weeks afterwards, some 70% of them. In Hurricane Maria in Puerto Rico, there was a lack of access to sterile syringes. There was a significant increase in overdose and overdose death. And then when you look at somewhere that other intersections, there's increases in alcohol consumption. There's comorbidity issues with anxiety and PTSD that also lead to risk of overuse and overdose. Obviously, very high stress situations. There's a self-medication dynamic. There's also a big issue of drug supply volatility. So just to mention a few issues. All right, now let's look on the other side. For first responders, public safety folks, what are they facing in these moments of extreme weather? Let's talk about heat first. So here's a study from a very hot and humid place in India, Ahmedabad. And there you had officers who were very exposed, standing in the sun in these intersections on their hot pavement, breathing the car exhaust, hard times. What they were reporting was a lot of basic physical unpleasantness, sweating, thirst, etc. We want to point out a couple of things. One is a loss of the coordination, body coordination. It's an important factor. And a loss of work capacity. So a lot of the officers who were interviewed in that were finding that they had to take extra days off from work because the experience was beating them down. So let's think about some ways that heat could add friction to encounters. And just with some just context. During heat waves, there's research showing that there are simply more 911 calls. So first responders are extra busy. In Boston, over 90 degrees Fahrenheit, a study showed you had 2% more police department dispatches, 9% more EMS, 10% more for Boston Fire Department. Going over a look at Missoula, Montana. There, with every degree of increase Celsius, there was a 1% increase in call volume. There, they also found that on those hottest days, the census block groups that had a larger share of individuals over 65 were in unemployed or out of the workforce. Over 65 or employed out of the workforce. Those are groups that had areas that had the highest rates of calls. In Portland, Oregon, places not used to super heavy heat. After a heat dome, their 211 calls were so frequent that they had to immediately switch from an 8 a.m. to 6 p.m. Coverage to 24/7. We're going to throw out a stigma issue here. If folks are so busy responding to so many cases, so many calls, for where stigma exists, we know so there's a lot of stigma towards people who use substances is a widespread problem. I don't have research on this, but I would suspect that may come up as an issue among first responders who are feeling rushed and need to move on to the next thing and might feel frustrated having to respond to substance-related calls when they're so busy. Just have to acknowledge that risk. And then also, what are people responding to? There's a lot of research showing out that heat is tied to violence. And so the police officers may be responding to more violent crime. For instance, this one study that I've pulled out shows a 9% increase in the risk of violent crime with every 18-degree increase in short-term average temperature. So they may be responding to more violent crime. More context. All right, so heat's going to adding friction different ways. And some of you all mentioned this earlier on that polling that heat can make people more irritable. Well, it does, right? It can increase irritability. increased negative hostile thoughts, increased frustration. It can impact people's sleep. It can impact cognitive function and self-regulation. So the self that they are bringing to bear, everybody in the equation here in an encounter, is impacted. It's also an interesting thing that came out of a somewhat famous older study in the Netherlands that compared, they did a firearms training course for police there. And they put one group in a normal temperature room and one in a hotter temperature room. And in the hotter temperature room, officers were more likely to interpret the suspects in the training as being threatening. So that's an interesting dynamic. So if you add that to a situation where people are very busy and where there may actually be more violence, this can also just add to the friction and risk of encounters. I'm going to go to wider disasters. Didn't occur to me to put in any 9/11 pictures here, but we have some that are related to Hurricane Katrina, which had its 20th anniversary last month. Disaster response takes a huge toll on people. As anybody who's done it knows, you've got the occupational stress in the moment. You've got personal stress because you may be worried about what's happening in your own home, your own family, your community, the trauma of what you see, the trauma of what may have already happened to you or to your family. Depending on the scope of the disaster, could really impact the first responder agency's ability to do its work. People may not be there. People may not be unavailable. You may have casualties, damage to facilities, communication systems can go down, and then that can also help feed a rumor ecosystem that can add its own problems. And then for law enforcement involved in emergency response, there can be a conflict in the duties between your human protection emergency response and your property protection law enforcement duties. And sometimes those can come into real conflict. Okay. Now let's talk about what we can do. There's a whole lot of badness that we've just talked about. So what I'm going to be talking about here are not really big, huge, not like major fixes. They're kind of like little adaptation things that people can try. And I'm going to ask you all to in a little bit like what you do. So there is basics of trying to cool down through air conditioning or shade, moving people to shade, hydration, any other things you do to cool down, like towels, ice packs, etc., cold drinks, trying to maybe move a little less fast. Clothing can be a real issue if people's uniforms are not breathable at all. So if there's some way to make a change there, getting some training, if you don't have it already, on heat illness can be useful in how you respond and how you see it affecting yourself and your colleagues and the people in the communities that you're trying to help take care of. Looking out for each other. I read a Reddit string about a group of police officers on how they deal with heat, and the suggestions that came out of it were basically keep the air conditioner on in the cruiser, work the night shift if you can, take your vacations in the summer rather than over the holidays if you can, hydrate a lot, and get used to it. Well, just thought I'd share that. Okay. Building trust. What can we do on building trust? This is always a challenge, right? Even at the best of times, even in the nicest weather. I would just recommend that one of the things to recognize is that everybody is suffering together, and that they will create extra challenges that can be met with some patience if you can find patience for it, because that's hard to find, especially when you're rushed. So the things to do to try to adjust to cool down the temperature of the moment, such as providing cooling, moving your encounter to a cooler place, under a tree, over grass, into air conditioning, if any of that is possible. De-escalation techniques to turn down the volume, to try to help everyone kind of bring a calmer and more effective demeanor to the encounter, if possible. Everybody's a first responder in these situations, so if you can do things to meet basic needs is key. Providing hydration if it's possible. And then there's this big issue of cooling centers and shelters. Want to be able to provide access to them. A lot of them don't accept people who use substances or medications. And so trying to connect people to that and to show you've thought about it, I think on its own can create some degree of trust building. This is a preliminary list. I mean, there could be lots of things you could do. On the bigger picture, without getting to the really big pictures of like, how do we address housing and global warming and all the issues regarding substance use and mental health, some adaptation policies that could possibly be pursued, such as providing adequate hydration and cooling supplies for personnel to take care of themselves, and maybe to distribute some. There's that uniform requirement issue, trying to encourage people to give themselves time to de-escalate in the moment. You see that within the de-escalation movement increasingly. That's always a challenge. And then, there are local adaptation and disaster planning efforts that happen, and public safety folks, first responders, and people who use substances and their communities and their service providers are not always at the table and talking about that or heard. And so to try to engage that conversation on its own would be useful. Okay, so let's go. I know I'm kind of pushing on time, but I'm going to ask if this can be considered part of the Q&A to go over to our next set of polling questions. All right, so do the agencies we all work have any relevant policies or procedures or trainings that are related to weather emergencies that you could mention here? Because I mean, I know this is not all like none of us were born yesterday. San Antonio's faced heat and humidity and hurricanes aplenty. So and other types of storms. So I would love it if you all had anything you could mention here. I'll give it a couple of minutes. If your phones and whatnot should already be logged into this system, so I think you should be able to just go ahead and submit some answers here. If anyone has any, thank you for providing this. I'll read them as they come in. We've got nothing I've heard of, meeting locations and collapsing among agency heads, mostly training on hurricane safety, no formal training on heat-related incidences, maybe this training only, homeless outreach teams and heat and before storms. Sadly, it's all ad hoc, compromises everyone. Collaborating, gotcha. I was wondering if I had heard that wrong. So sorry for moving that. First aid by exit doors, trainings on heat stroke and cold exposures. No one's prepared. Cooling centers, just some info, some emergency response training. Good. Shelter plans for MOUD. That's great. All right. Well, then I know I'm pushing on the time here, so let's move on to the next. Are there things you all do that you'd like to share with the community here to reduce friction in encounters during intense weather? Whether it's what you do or what some you recommend to your colleagues. I know you all have come from a lot of different backgrounds, but I imagine you probably have some tricks that you already do. Great. I love seeing that. Offering the cold drink, organizing plans for evacuations, being conscious of your own response to intense heat. That's wise. Offering water if available and moving discussions to sheltered areas. Provide cold water and drinks to clients. Great relationships and community events with first responders. Preconditioning for heat. Interesting. All right. That's a good idea. Leadership has to initiate. Yep. Offering to pick up cold treats for the office. Get to know your local sheriff. Good idea. All right, I'm gonna hop over to the next one. Pre-hydrate and plan for restrooms on shift. Wise. Offer water, get assistance, connect to local services. All right, and then building trust. What do you all do currently during intense weather to try to build some trust? Now, I think some of the things you've just said may also do double duty here. But if there's anything particular that you find helps on the trust front, y'all the ones who are doing the work. So to share it with each other would be great. Connect with neighbors, checking in. Bring water for the distribution. Great idea. Public chat, all right. Talking about it. Yeah, talk about what we're experiencing. Checking in, sharing supplies. All of the above. Providing the specific shelter locations with the key availabilities. A meeting plan. Collecting items to prepare, such as canned food. All right, this is great. Thank you so much. I'm going to move on to the last one now, and then we're going to end, as I know I've eaten up a lot of time here, and I really appreciate you all listening. This is, these are topics that have not been very much thought about or acknowledged across the public safety space, across the country. There's just a bit of increasing notice, and there are some areas that have been researched a bunch, but some that haven't. And so in among practitioners, it hasn't, the dots have not been drawn in a lot to make these connections. And so I'm sure I missed a lot in this presentation, even recognizing that I was only supposed to have 20 to 30 minutes, including Q&A. So if there's anything you think I should, that jumped out that was missing, please chime in. And while I do that, I'm also going to go over here and look at the chat to see if we have any questions to mention. Don't see any. Yeah, right. Examples of existing training programs, good call. So on the question, what does the research show as it really works to support folks with SUD within the context of extreme weather? That's an excellent question. If it's specifically regarding extreme weather, I'm not sure that research exists, but it should. There is some increasing interest now that's just kind of bubbling up now in the research world about impacts of weather on people with SUD and specific SUDs, impacts on the support environment and the treatment environment, and on the professionals in those fields, and some policy recommendations on what to do, but it's new. So yeah, I think so. A lot of these things they're recommending are more calls for action for next things, and from desperation to passion. I like that. While I leave this up, does anyone want to hop on with any unmute yourselves and ask any questions?
I was going to share a comment if I could.
Please.
So with a last name of Clancy, it should be very obvious that I come from a very long line of cops in YPD specifically. So, hey, Brandon. Immediately after September 11th, I was hired by the Austin Police Department, and admittedly, I lied on the psychological exam because I needed a job. And I worked there for a couple years, and I ended up working a call where an officer that I knew personally was T-boned and died. And I ended up having time off that weekend, and I went home and I came back, and this was like, they made you have landlines. They didn't want your cell number because of weather issues and cell line breakdown. They wanted you to have a landline. And I had phone calls from my supervisor, his supervisor, the chaplain, the chief. They had come to my house to make sure I was okay. And I had completely blocked out what happened. And I realized how much compartmentalizing I was due to work, to have to work that job. And I left soon afterwards. And years later, I listened to a documentary of another officer that was killed in an accident. And that mic click came up. And I remembered what happened. And it had been years since I thought about that event. I think that I also share that I worked for the American Red Cross during the time of the highest hurricane season in recorded history. And they asked me to do logistics during Winter Storm Uri. And, I ran a medical logistics company. I'm a pharmacist. I know how to coordinate that. And what actually ended up happening was, and instead of just, people calling for water or, hey, I need, a replacement of my medication or whatever, they logged 5,000 calls for service that I had to go through every single day. That included things like apartment complexes and nursing homes calling to say they had no power and they were freezing. Multiple death notifications, just a lot of things that were, not in the job description and ended up being really traumatic. And I also quit right after that. And it wasn't until after Winter Storm Uri that they mandated mental health screening before and debriefing after. So I just want to impress upon everyone that if we don't support the mental health of our first responders, they will burn out and leave. And then what happens, obviously, is you have already understaffed departments having seasoned people leave, and then you end up hiring younger individuals, people with less experience, people that may be less qualified, and you end up having more incidents that affect the population that we're talking about. And so I always want to emphasize that bringing first responders to the table when we're having these discussions and supporting them in addition to recruiting them to support us is incredibly important for improving this cycle that we're talking about. Thank you so much for this presentation.
Thank you for sharing that. I think I've probably come to the end of my time, so I'm just going to say thank you. If any of you are interested in looking up any of the other connections that we've been looking at the Climate and Public Safety Program, it's the website is here, healthinjustice.org/caps, and this tiny map there kind of goes into it. But I'm going to hand over the floor now. Thank you all for listening. I'm really grateful.
Yes, of course. Thank you all so much. Thank you for that great presentation, Jeremiah. Thank you, Dr. Clancy, for sharing your experiences. And thank you to everyone that participated in all of the Q&A and stuff. With that, I do want to move over to some brief announcements. Cato, if you could pull those up, please. Thank you. To claim your CEU credits, you must complete the post-session survey in the chat or by email sent after this session. Complete the post-session survey and select yes on the question, are you applying for CEU credit for today's ECHO session? Your certificate of completion will be sent to you 2 to 3 weeks after the session date. If you have any questions, email bewelltexas@utesca.edu. And when you complete your post-session survey, you help shape these sessions around your needs. We created this series for you, and your feedback truly matters. Your ideas, experiences, and suggestions guide how we plan future sessions, what topics we cover, how we deliver content, and the kind of support that we offer. Please take a moment to complete the post-session survey. We're listening, and your input helps us make this ECHO session even better. Next slide, please. The Center for Substance Use and Training in Telemetry offers technical assistance for various substance use disorder needs and topics through our network of subject matter experts. To request technical assistance, please complete an online request form through the link in the chat, and we'll be more than pleased to help you. Next slide, please. The Texas Substance Use Symposium is back March 2nd through the 3rd, 2026 in San Antonio, and we're thrilled to reunite our statewide community once again. For the latest updates, visit txsus.org. Next slide, please. Please join us for our next Public Safety ECHO session on Thursday, October 9th at 11 Central Time. And let's go ahead and move on to our case presentation for today. Cato, if you could bring up the case form, please walk us through this case. Maria, you can go ahead and walk us through your case.
Sorry, I apologize. Okay.
There.
So this case is about a female, 4-year-old female, that is on probation for a burglary of a habitation and is in the substance abuse caseload. Her drug of choice is fentanyl, and she was ordered to complete a Safe P program. And let me see. Okay, so the program, there's an incarceration of 9 months, 7 to 9 months, and then she reports afterwards to a transitional center, which is 60 days to 90 days, depending on the offense, or if it's something that she's going back to. And then she does an outpatient aftercare program in the community. This program is for to help support them with their sobriety. She completed the program, and right as soon as she completed the program, there was situations with her where she was living. I went out to do a visit, and it was just it was poor living conditions. She lived in a little RV, but surrounding the area that she lived in, there was a lot of substance use in that area. And she struggled with building relationships. She didn't trust anyone. She came from a background of foster care. And so she was having a really hard time building relationships. And I think her concern was also she was in an abusive relationship, and the abuser was in prison, but was soon going to be coming out. So I think that was some of her concern. The main barrier in her ability was the ability to build relationships and trust others. She did persevere. Like I said, she did finish. She did want a change in her life, and she wanted to maintain her sobriety. And she completed the program successfully. So I guess the scenario we're presenting is maybe some other resources out in our community that could have supported her sobriety to maintain and be able to build these relationships. Because she was willing to accept this. We did provide her with integral care, a new for any counseling services that she needed. We did provide her services for sober living and communities for recovery for a peer group specialist.
Thank you so much for that presentation,
Sure.
Maria. With that, so I want to open up the floor to our team. I see Lindsay, you have your hand raised. Please go ahead.
Yeah, was she offered any type of like medicated assisted recovery or like opioid or mood?
She did at the end. What happened was her relapse came after she completed this program. Right soon after that, we do have a court docket where all the clients that are in this program get the chance to go before the judge, and we discuss, you know, how they're doing in their progress in treatment. And she completed everything. She was going to go to court, and then she had her relapse. She took it upon herself to not reach out to us to help her, but she did find a place to get some help for some medication for her opiate use, and she was able to get on it. So the other part was when she went to court, the judge offered her an opportunity to do a different program, which was shorter, but it's going to allow her to be out in the community. And we're providing services so that she can you know, maintain that sobriety now, because in order to do the new program that she had to do, it's a residential, she had to be off of the medication. She was not allowed to be on that medication to be part of this program.
So for me, that would be a great chance for some advocacy work, because being on medication for opioid use disorder is the same thing as being sober. Like, you wouldn't tell somebody to get off of their psychiatric medications or their heart medication, right? So why would we tell them to get off their mood?
Right. And I agree with you on that. But that's the requirement in these programs. These facilities will not allow them to be on that medication to go back in.
Well, then perhaps that's not the facility for her. Maybe she needs a different process or program. If she's, we've already shown that, you know, relapse is an expected part of the journey. So we have to do everything we can to prevent that process. And maybe then that choice of a facility is not a good one for her. That's my point, number one. And number two, maybe we need to find a place where she can get community, perhaps someplace where there are other victims of domestic violence, or there's other types of connections she can make in her community, whether it be with a faith-based or something like that. It doesn't sound like that environment she's in is safe for her, or a therapeutic environment. So maybe we need to rethink where she's going to be during the next phase of her recovery process.
Thank you. Yes, I agree. We did offer her other conditions, right? Where she'll be allowed to live in a sober living home. At that point, she can opt to use that kind of medication to allow her to, and then she will be connected again with the integral care part of it. But like you said, the resources for maybe living in a place for domestic violence would be an option.
Hi, my name is Cynthia Mendiola, and I think I agree with a lot of the comments that have been said. Sometimes from my experience, we've always had to build a treatment program or a treatment plan around the individual's needs, and that always includes like bringing in all of the different players that would support this person's recovery, as opposed to like eliminate the medication because it's not required and we can't take it in this program. And so I think you're in the right path, looking at the sober living environment, looking for others that would support the trauma from her domestic violence, and then also including the fact that she's on medication. And so, and it's really difficult for probation officers to find that resource and start building that treatment around her, because there aren't any fit all types of programs with some of our individuals on supervision. So I think you're in the right track, and I really appreciate the work that you're doing to try to build around her.
Thank you. I appreciate that.
So is Dr. Miramontes again. So the other thing that came to mind is, so we have a person who has had trauma. We have a person who is struggling to connect to the community. We have someone who is using substances to try and help with that trauma, that pain. So the next step is, where are we at with her assessment for behavioral health issues or psychiatric issues? That would be, because most of our patients that, a lot of my patients, I should say, are dual diagnosis. They're using substances because they're trying to treat their pain or their trauma or their psychiatric issue, and vice versa. But so usually the substance abuse is merely a coping mechanism, a maladaptive coping mechanism in this case, for a psychiatric issue. So what have you done to try and see about stabilizing her psychiatrically or assessing her psychiatrically?
We did have her assessed, and services were available to her, but she denied the services. We cannot make her, participate in any kind of mental health services. So that's where, we're stuck. I mean, we can give her the services. Like I said, our program, while they're in this program, the services are free for her. But she did refuse.
That's another opportunity to re-engage. Say, look, you're having a problem with relapse. You're having a problem connecting with people. We know you have had some rather significant life issues. Perhaps we can work on those together. Especially the anxiety of her offender coming out of prison. That could lead all kinds of anxiety, and we're bringing back those memories, and that's going to lead her to potential use.
I agree. And that's another conversation that we can address now that, I mean, she's agreeing to address other issues that she didn't want to before. Like I said, she struggles with the relationship. So I think now it's an opportunity to go there and have this conversation again.
And I did want to say, so I saw that Sandra, you posted a question in the chat. Are you able to unmute yourself and ask your question? No, I can go ahead and ask it. So it looks like she asked, does the patient have any family, any friends?
She has, she does have a support system through her NA classes. So she has a sponsor that she has built a relationship with. So that's one. The other relationship she has is with a grandmother of the abuser. So that's also probably not the best relationship, but she's just very, she does have a sister, and I think that was the fear, is her sister not being in her life because of all the relapses and her drug use. So now that right before she went into the program, she did speak with her sister, and it looked like her sister was understanding and was going to assist with her treatment.
That's great. It sounds like she does have a lot of support.
Yeah.
I'm sorry. I forgot. I mean, I didn't forget. I might have missed the name of the program. What's the name of the program?
She was in before, it was Safe P. Now she's back into the judge gave her an opportunity to do SMART. It's a residential treatment.
Okay, so the SafeP, that's pretty much like a almost like a prison, a drug program in a prison setting. Is that correct?
That's part of it, but when they come out, they do continuum care, which is what I do. So
Okay.
that's where we work with them in providing them where to attend the outpatient treatment and the residential treatment, and learning skills and stuff like that. So we follow along with them until they complete that program, which is about the one in residential aftercare is 60 to 90 days, and then the outpatient treatment is 7 to 9 months.
And so that's that transitional program that follows the SafeP is what you're saying does not allow the medication assisted.
Right now that she completed this one, great, right? But then, of course, came the relapse. The judge did not allow her to go back because this is her second time she's done this, right? So she was not allowed to do this, but the judge did want her to be out in the community, wanted her because she tried so hard in this program and she was successful.
Great.
Of course, came the relapse, but so the judge was going to allow her to do this program, which is smart, a lot shorter, but it still gives us an opportunity to work with her by doing aftercare and
And building her treatment program around.
building exactly. Yes.
So can you explain to me what a SMART program is? This is the first I've heard.
It's an also residential, but they're allowed to go out. They get passes to go out in the community. Again, we give them the services that they need out in the community so that they can get linked. They'll have sober living, prior to her leaving that facility. And an opportunity to get jobs, get linked with mental health services as well.
So is the SMART program a component of the criminal justice system?
Yes, it is.
Okay, thank you. I appreciate clarification.
Sure.
Great points of discussion, everyone. Before we move on to our summary recommendations, I want to give everyone a moment more. If anybody has any additional questions they'd like to ask Maria. Randy, I see that you posted something in the chat. Do you want to unmute and add anything or share your comment, add anything extra?
Real quickly, I chatted it because I have construction going on in my house, so you're not gonna be able to hear me. But I was just stating that medication-assisted treatment should not be denied through the court system either way, because that's part of the treatment, that's part of the recovery. The relapse has nothing to do with being on the medication, that's part of their recovery. So there should be some revisits there, because at the end of the day, if you're a soda drinker, you take your Dr. Pepper away, you're going to go 2-3 weeks, you're going to go back and get that Dr. Pepper. It's just like being on the medication assisted treatment and any other treatment.
Yeah.
So
yeah, thank you. Yeah.
That's not
that's
fair to the person in recovery.
I think that's correct. I totally agree with you, but it's sometimes what happens, and I'm talking from the criminal justice aspect because I worked in the field, and sometimes it has a lot to do with providing that education specifically to the judges and the criminal justice people, that just to keep them up on what recovery is all about and how the dynamics of the addiction works with individuals, and it's a very long process to kind of change that mentality sometimes. But we're working at it, aren't we, Ms. Ortega?
Yes, I agree. I agree.
So really, you could also there's lawyer services that will come in and help it, because they can actually legally they have to allow somebody to continue their mood treatment. It's a disability rights what is it called? The ADA stuff. Sorry.
I during these staffings that we have the attorneys, we have the judge, and the whole treatment team is there when we're staffing these cases in order to provide them the right treatment. But they are aware that these facilities do not allow that. Not at this level.
I was saying more that like if it might be a good resource to provide to your participant, like
Oh,
lawyer
yes,
referral
yes.
services.
Right. I agree. Thank you.
Great. Thank you so much, everyone, for sharing your respective thoughts and opinions.
I have one more question, quick
of
question,
course.
just one more before it gets loud again. So are they court ordered to go to these specific treatments? They can't
Yes,
go anywhere else that is actually gonna benefit them? They're court ordered to go to these specific places?
Yes. Mhm.
Okay.
They're
And I'm assuming the lawyer is court ordered through the system?
right.
It's not their own private lawyer? Okay.
No.
Thank you so much. So Jeremiah, if you could please give us a summary of recommendations for today.
Sure, will do. Obviously I talked a lot during my presentation, so I'm just going to talk about the case. But thanks everyone for being here. And it was a great discussion around the case. I think it illustrates a bunch of things that you hear about a lot, where there have court-based programs that want to help, but have their very specific limitations, and those limitations are often not patient-centered, and they're not based on the science, and such as having these very clear specific rules that are not based on what the suggestions of a clinician and the patient, but instead are what the law says or what the policy says, what the judge says, and they may not align. And then you have these rules that say you can't go to a residential facility that offers MAT, as Brandy and Lindsay mentioned. And so Lindsay suggested this be a moment of advocacy to encourage the programs to allow a referral. And there is a growing body of law saying that if they receive federal funds, they actually have to be providing and offering medications to people who have a prescription for it. So that was suggested. Dr. Miramontes mentioned that suggested offering residential environments that do offer medications, or that can provide more of a nurturing community, or can offer, then there's psychiatric services, but Maria mentioned that the client was offered them and turned them down. And then Cynthia offered this kind of positive approach, as opposed to kind of the kind of narrow approach that clearly this program kind of demands on you, and kind of hamstrings the probation officers who are trying to provide something more creative in order to build treatment around the person's complex needs, which are obviously challenging, and program doesn't seem to want to line up with. So, and then there's interesting notion of how programs, especially kind of criminal justice system related programs, tend to not quite, don't cope with return to use very well, and how to adapt, or if the program itself was actually working for the person once they've graduated from it, give them a chance to come back to it, if that's the right thing for the person. So big challenges. I think that sums it up.
Great. Thank you so much, Jeremiah. And thank you all for joining today's ECHO session. As a reminder, to earn continuing education credits, please complete a post-session survey using the link in the chat. If you would like to present a case, please email BeWellTexas team at bewelltexas@utasca.edu. We look forward to seeing you at our next session on Thursday, October the 9th at 11 a.m. Central Time. Have a great rest of your day.